Well, let me illustrate a case here and show you how the synthesis of the carpentry and the biology comes together, and how an Osstell, or understanding the ISQ, helps us make decisions. This is a patient who's been in my practice a long time. She's 78. She's been on bisphosphonates, has very large mandibular tori, very limited mandibular opening because she has some degenerative joint disease, so she only opens about 15, maybe 20 millimeters total. She's got resorption underneath the crown on a lower first molar. And on top of that, she has fairly poor mandibular bone density. So the question is, what do we do with her? She wants to replace this tooth. She has ample funds, and she wants to do something. So we did a flapless extraction, very challenging, but managed to get the tooth out and the socket, leaving the socket intact. I grafted the residual socket with autogenous bone chips plus demineralized bone mineral, and placed an implant in what I thought was the septum. Turns out it was more towards the mesial socket. And when I finally put the healing abutment on it, I was able to relatively easily rotate the implant with the healing abutment. So I'll ask you for the first question. Let's do some voting and try out our system here. What do you do? Marcus, you have?
Yep. Switch.
So what do you do when you place this implant? It rotates with the healing abutment. Do you remove the implant? Do you remove the implant and graft the socket, or do you leave it alone?